You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 8, 2023. This week, I'm going to talk about three aspects of the recent American AFib guidelines and a possible new treatment for POTS, or Postural Orthostatic Tachycardia Syndrome. But before I start, I wanted to say a few words about the Brazilian EP Society meeting in Rio de Janeiro last weekend. Wow, what a meeting and what a country. I want to say thank you to Sobrak and to Dr. Edward Saad for the kind invitation and amazing hospitality. I am struck by the strength of EP being done in Brazil. I was speaking with some very young EP docs there, and while I was going on about boring old pulmonary vein isolation, they were telling me of their epicardial VT ablations due to the presence of Chagas cardiomyopathy. Also, a quick short note to my listeners in Porto Alegre. First of all, thank you for listening, but if I make any flubs today, it is because I have done so many ablations this week. Yes, of course, I have a podcast, but I also do hundreds of ablations and devices per year. We don't have Chagas cardiomyopathy here, but we do have a lot of ischemic VT that requires ablation. All right, first topic, AFib guidelines. Just 2 days before my debate in Brazil with Dr. Luigi Dubious, my friend, we were debating on AF ablation and heart failure. The American authors of the 2023 ACC AHA guidelines published their new update. It's a massive 156-page document, and there's no way to cover it all, but I'm going to comment on some of the particulars and some of the new recommendations. Now, the first, and I think the one that got the most excitement online, is that the American guideline writers have upgraded to Class 1A the use of AF ablation in patients with HFrEF, or heart failure with reduced ejection fraction. This is in section 9.2 of the document. Now, notably, the 2019 guidelines had AF ablation in heart failure as a Class 2B, so it went from the lowest recommendation to the highest recommendation. Now, here's what the actual statement in that colored box reads. Inappropriate patients with AF and HFrEF who are on guideline-directed medical therapy and with a reasonable expectation of procedural benefit, catheter ablation is beneficial to improve symptoms, quality of life, ventricular function, and cardiovascular outcomes. Okay, my comments. I'm going to do my comments in 4 chapters. Chapter 1 is that I have some content expertise here. I mean, AFib and AFib ablation is the number one thing I do. My approach to most patients who present with AFib is more as a psychologist than a cardiologist. I reassure, I remove fear, I make clear that we will help patients with AFib, but we can usually go slow and often treatment does not require any major procedures. That is for most patients, but there are occasional patients with AFib that do require prompt and aggressive action. These are the patients with AFib and HFrEF. These are often men, often ambulatory from the heart failure clinic. Let's say they have a bad ventricle, they're doing okay on guideline-directed therapy, then boom, AFib hits and they decline. In these cases, aggressive action to restore rhythm is appropriate, and AF ablation is often a core way to do that. Now, there's another fraction of patients with HFrEF are those patients who present with AFib of a month or so duration and they have tachycardia-mediated cardiomyopathy. These patients too need rapid and aggressive therapy, first to stabilize with rate control. I use lots of digoxin for that, and then consideration of rhythm control. The thing is, though, for every one of these patients, I see 10 patients with AFib that can be treated slowly and with giving peace a chance. All right, Chapter 2 about this new guideline. I want to talk about the modifiers in the recommendation statement. The first one is quote-unquote appropriate. Appropriate modifies patients. What does that mean? Well, in my lecture in Brazil, I showed a number of studies that document the many comorbidities in patients admitted with the diagnosis of heart failure. And the take-home message is that the vast majority of patients who get admitted to an inpatient service who have heart failure have many, many comorbidities. In one sample of American inpatient diagnoses, greater than 80% of heart failure admissions had a high Carlson comorbidity index. Now, if you contrast that with Table 1s from the heart failure and AF ablation trials, like, say, Castle AF. In Castle AF, the mean age of patients was 62 years, mostly men. Same with Castle HTX and the ATAC trial. Again, these were young, male patients with minimal comorbidities. The point is that the supporting trials enrolled much different patients than we see in the inpatient service. Now, another modifier in that box, that statement, that recommendation, was, quote, a reasonable chance of success. Now, I admit this is a gray area, but what I take from it is to try and emulate trials when we translate evidence. Now, we see a bunch of older patients with dilated left atriums, longer duration of AFib, fine atrial fib waves on the ECG, LV scar. My friends, resist the urge to ablate these patients. It's not going to work. I mean, PV isolation with or without posterior wall isolation or roof lines, it's just not going to work. There's too much structural disease. Now, another common group that we see here in the southeastern United States is patients with morbid obesity. These patients, too, have oodles of electrical and structural atrial disease. PVI is unlikely to work. Now, my friend Luigi Dubious will say, John, you have to do more than PV isolation. And to this, I say, yes, I understand you probably could be right, but can you show me any data that refutes the STAR AF2 trial, which found that no extra ablation other than PVI was any better? Can you tell me where I should do this extra ablation? Should I isolate the appendage? Should I do anterior wall lines? Should I do posterior wall? Should I do right atrial lines? Now, the answer is Luigi Dubious is a great friend, and he can tell me a lot of things about olive oil and Primitivo, but I don't think he or anyone can say where else to ablate outside the PVs for patients with advanced AFib and structural atrial disease. All right, the third chapter I want to comment about this. I want to argue with the writers about the level of the recommendation. They gave this the highest level, 1A. Now, the writers will support a 1A because their guideline recommendation says it's specifically to improve symptoms, quality of life, ventricular function, and CV outcomes. And they will say that there are multiple RCTs and 3 meta-analyses supporting that recommendation, which is true. But I want to say Castle AF trial dominates most of the meta-analyses. And Castle AF is a positive trial. It found a 38% reduction of the primary efficacy endpoint of heart failure hospitalization and mortality. Yet, as much as I love my friend Nasir Marouche, the trial has limitations and we should be open about them. First, Castle AF was unblinded. Unblinded trial raises the possibility of performance bias. It's not nefarious, it just is. Secondly, Castle AF was underpowered due to early termination. Thirdly, there was substantial missing data in Castle AF, and this missing data was uneven, with more patients lost to follow-up in the active arm versus the control arm. And the primary analysis was based on a small number of events. Finally, Castle AF investigators screened more than 3,000 patients to enroll 360 patients. So this is a very highly selected population. There are many, many reasons, these reasons, to be cautious when we're translating this evidence at the bedside. Now, supporting a cautious view of Castle AF was the non-significant results of a similar trial called RAFT AF trial. RAFT was a Canadian trial of about 400 patients with heart failure and AFib The two treatment arms were AF ablation-based rhythm control versus rate control, which could include AV node ablation and pacing. Nearly 1 in 3 patients in the rate control arm had AV node ablation and pacing, and this was before conduction system pacing. RAFT was terminated early due to futility, and the end result was non-significant for the primary endpoint of death or heart failure events. Though it did get close to significance in the end, there was only a difference of 14 primary outcome events in this unblinded trial. Now, another problem with the meta-analyses is that when you apply the Cochrane tool, which is for individual studies, and the GRADE framework, which is for the overall body of evidence, to assess the risk of bias and the strength of the evidence to these trials, you find that all of the trials that are included in the meta-analysis are at high risk of bias, due primarily to their unblinded nature. So, in the end, even though there are 3 meta-analyses, any neutral assessment of this evidence would lead to overall low confidence. So, in sum, therefore, I know why the authors chose 1A, but I think the components of the evidence warrants more caution than this highest level recommendation. A 1A recommendation may tempt over-enthusiastic ablation doctors to ignore the important modifiers, appropriate patients, and reasonable chance of success. My friends in electrophysiology, please don't go overboard with AF ablation in these patients. Now, Chapter 4, I want to close this discussion with a note to my heart failure colleagues. If any heart failure colleagues listen to this podcast, this is specifically to you all. One thing that I sense, and I see it sometimes, is that there's a barrier between heart failure and EP. I am often referred patients with heart failure and AFib late in the course. There's this great push to put every heart failure patient in the we must get them on big 4 drugs category fast. And that is fine, but sometimes the problem with heart failure is AFib, and sinus rhythm is the best heart failure therapy. We should always remember that A, most of the heart failure trials had either no or very few patients with AFib, and B, there's a very important meta-analysis by Kotecha. It's in the Lancet, and they found that beta blocker therapy reduced mortality in patients with heart failure who were in sinus rhythm, but had no effect for those in atrial fibrillation. So please, my friends in heart failure, get us electrophysiologists involved early when there is AFib or left bundle branch block. Sinus rhythm is sometimes the best treatment for heart failure, far better than beta blockers and sacubitril valsartan. All right, second topic in the AFib guidelines. Early rhythm control gets emphasis. So the number 5 top take-home message from that 156-page document reads, quote, "With the emergence of new and consistent evidence, this guideline emphasizes the importance of early and continued management of patients with AF that should focus on maintaining sinus rhythm and minimizing AF burden." And this emphasis is based on the early AF ablation trials with cryoballoon, and of course the East AF Net 6 trial. Now, I've discussed these trials many times, so I will be brief. Okay, the STOP AF and early AF ablation trials were both cryoballoon versus antiarrhythmic drugs in patient with relatively new AF, and both these trials showed that cryoballoon ablation is better than drugs. But the endpoint of these trials was AF episodes, not outcomes. I strongly believe we should be going much slower in patients with relatively new AF. We can reassure these patients, we can wait, we can treat risk factors. Remember that lots of new and short duration AFib will resolve over time and removal of triggers. Now, I'm not saying wait years and let the AFib become persistent. Just resist the urge to go to early AF ablation. Please give peace a chance. Okay, a comment on East AF, which is early rhythm control. And again, I'll be brief, but East AF, remember, has important limitations. This showed that an early rhythm control strategy versus a conservative, mostly rate control strategy in patients who had relatively new AF led to lower cardiovascular outcomes. Now, importantly, East AF was not an ablation trial. Less than 20% of the early rhythm control strategy had ablation. And East was a positive trial, but there is a serious concern for performance bias because there was much more interactions in the early rhythm control group. What's more, go to the supplement of East AF. 60% of the conservative arm was in sinus rhythm at a year versus 80% in early rhythm control. So how, my friends, does a delta of only 20% more patients in sinus rhythm drive a reduction in cardiovascular outcomes? My answer is it can't. Maybe if it was 90-10 or 80-20, but that's almost no difference in sinus rhythm. So I think the reason why EAST-AF was positive was because patients in the early rhythm control arm had much more interactions with physicians. And again, performance bias isn't nefarious. It's just one of the common things that happen in unblinded trials. All right, the third aspect of the AFib guidelines that I want to talk about is an upgrade of percutaneous left atrial appendage closure or occlusion. The authors say this in their take-home messages. This is point 8 of the 10 top take-homes. Quote, left atrial appendage occlusion devices receive a higher level class of recommendation. In view of additional data on safety and efficacy of left atrial appendage occlusion devices, the class of recommendation has been upgraded to 2A compared with the 2019 update for use of these devices in patients with long-term contraindications to anticoagulation. Now, let me go to their text in section 6.5.1. They write, and this is very early on, and it's a declarative sentence as if it's written in stone. They write, quote, RCTs have demonstrated percutaneous left atrial appendage occlusion to be non-inferior to warfarin and DOACs for stroke and systemic embolism with a reduced risk of major bleeding. And they cite citations 1 through 4. Now, this statement reads as if it is obvious and true, but it is not exactly true. And I want to be specific on the citations. Citation 1 for this statement is the PROTECT-AF trial. And yes, PROTECT-AF found that left atrial appendage was not inferior to warfarin, but it did not pass FDA muster due to many internal validity issues. FDA mandated a second trial called PREVAIL. Citation 2 was the PREVAIL trial, and I will read directly from their 5-year paper so you don't think it is me being biased. This is from their 5-year paper that I'll cite. It's in JACC. Quote, the 5-year outcomes of the PREVAIL trial revealed that for the first co-primary composite endpoint of stroke, systemic embolism, or cardiovascular death, left atrial appendage occlusion did not meet the non-inferiority endpoint. Now, it is true that the second co-primary endpoint of stroke and systemic embolism, excluding the 7 days after the procedure, met non-inferiority. This is extremely dubious because A, what patient ever can exclude the 7 days after their procedure? And B, it met non-inferiority in this second co-primary only on risk difference, not rate ratio, and the upper bound of the rate ratio was nearly 5, meaning if you accept non-inferiority in this second co-primary endpoint, you have to allow that left atrial appendage occlusion was 5 times worse than warfarin. All right, citation 3 of this statement was the combined PROTECT and PREVAIL meta-analysis. This showed no difference in stroke or bleeding, not lower risk of bleeding, same difference compared to warfarin. But of course, meta-analyses are not non-inferiority trials, and the results in PROTECT and PREVAIL were widely divergent, with many more ischemic strokes in PREVAIL. Citation 4 was the PROG 17 trial. This was left atrial appendage occlusion versus DOACs, and yes, it found top line that left atrial appendage occlusion was non-inferior to DOAC, but the authors of this paper combined stroke and systemic embolism, which are efficacy endpoints, with bleeding, which is a safety endpoint, and when you combine endpoints expected to go in opposite directions, they cancel each other out and non-inferiority is reached. This is not how non-inferiority trials are supposed to work. So I know I've said this before, but it's worth reiterating that the entire foundation of this procedure rests on shaky grounds. Now I want to speak to the new upgraded recommendation of 2A. They say this is because of additional data. So when you go to the document in the discussion of this point, they cite first an evolution registry study. Evolution, this is a deeply flawed registry study because evolution was a voluntary registry wherein patients were included at the discretion of the investigators. So my gosh, do you think that investigators include their worst cases? They also cite the great new Pinnacle Flex study. This is by Carr et al. In Circulation. I'll cite it. This was an IDE study looking at the results of the newest Watchman Flex device. So this was a study, Pinnacle Flex was a study of 400 patients. They had 12 strokes in their first year. So that's a 3% incidence. Compare that to the 1.7% per year incidence in Rocket AF, which had a similar CHADS-VASc cohort. Also, in this great new device study, they had a rate of major bleeding of 7.9% at 12 months. Okay? Contrast that with a rate of 3.6 per year in the Rocket AF trial with rivaroxaban. So I'm not convinced that Watchman Flex is the answer. Now, the authors have not cited the recent 12-month data from the Swiss Apero study, which I've mentioned previously on this podcast. First author here is Galea. It's in Circulation as a letter 2 months ago. Swiss Apero found, this was an Amulet versus Watchman study, it found that 50% of both groups had, quote, patency of the appendage when looked at by CT scans. So I know I said that kind of fast. Here's the translation. Half of these devices put in experienced centers failed to completely close the appendage. And we know that peri-device leaks are terrible because they increase the risk of stroke. And you wonder why ischemic strokes were so much higher in PREVAIL. Okay, one final comment on the second recommendation in the left atrial appendage occlusion section of the new guidelines. The little colored box reads, in patients with AF and a moderate to high risk of stroke and a high risk of major bleeding on oral anticoagulation, percutaneous left atrial appendage occlusion may be a reasonable alternative to oral anticoagulation based on patient preference, with careful consideration of procedural risk and with the understanding that the evidence for oral anticoagulation is more extensive. So I'm going to have to take a deep breath here. I don't know what to say about this. The two additional citations that they include, citations 5 and 6, include a non-controlled registry from 2013 and evolution, which I've already explained is deeply flawed. So the idea of telling a patient that appendage occlusion is a reasonable alternative to oral anticoagulation is nothing short of egregious in my opinion. There's no convincing data for that. Using patient preference sounds nice, but too often I am sent cases or I hear directly from patients that patient preference is being used as a coercion technique. I worry that our field is really going down a precarious moral road here. I am not religiously opposed to percutaneous left atrial appendage occlusion. I have referred patients who have, say, electrically isolated appendages from a prior ablation and had stroke on oral anticoagulations. I referred them for closure. I am also not against studying this technique, though that should have been done before we have done hundreds of thousands of these implants. And I am impressed by left atrial appendage closure, as shown in the LAAC 3 trial. The surgeons have shown that the appendage can be an appropriate target, though recall that in LAAC 3 that included continuation of oral anticoagulation. I'm concerned that there's way too much enthusiasm for this preventive procedure. It's preventive, a preventive procedure that starts with a, say, 3 to 8% major complication rate. I dare you to look critically at the evidence for this. It's not strong. And if you convince a patient to have percutaneous closure rather than oral anticoagulation, I think you're on very shaky grounds. And one final comment on the matter of absolute contraindications to oral anticoagulation. You think this is a great indication for appendage closure. Okay, now I ask you, what happens to this patient who cannot take oral anticoagulation because of bleeding when he or she develops a device-related thrombus? And if that happens, say, 3 to 7% of the time, you have definitely harmed your patient. Okay, final topic today is a small study on POTS, Postural Orthostatic Tachycardia Syndrome. There's a group at the University of Oklahoma interested in autonomic innervation of the heart. Dr. Stavros Stavrakis and his team have done work previously on use of a transcutaneous vagus nerve stimulation for treatments of AFib and HFpEF. I know this sounds crazy, but it is a clip on the tragus of the ear. That's it. They use below pain threshold stimulation, which exerts anti-adrenergic and anti-inflammatory effects. Their most recent study involves treating patients with POTS, perhaps our most vexing condition in EP and cardiology. The journal JACC EP published this randomized controlled trial, and this was a simple experiment. Active arm was transcutaneous vagal nerve stimulation. The sham was an ear clip on the ear lobe instead of the tragus. Stimulation was for 1 hour over 2 months. The endpoints was postural tachycardia, heart rhythm variability, serum cytokines, and anti-autonomic antibodies. The mean age, young patients, 34 years, all female, 26 patients total, all with well-documented POTS. So postural tachycardia was significantly less in the active arm compared with the sham arm. At 2 months, the postural increase in heart rate was 17 versus 31, and that was statistically significant. Also, anti-adrenergic autoantibodies and inflammatory cytokines were lower in the active arm compared with the sham arm at 2 months. Heart rate variability was better in the active arm. There were no device-related side effects, and however, symptoms using a 31-point questionnaire were not significantly improved. And really, this is the first time that the intermittent transvagal neurostimulation of the auricular branch of the vagus nerve at the tragus over a 2-month period attenuated orthostatic tachycardia. And their concluding statement was that our results support the emerging paradigm of non-invasive neuromodulation to treat POTS. And mechanistically, this effect appears to be related to the reduction of anti-autonomic autoantibodies and inflammatory cytokines and improvement in autonomic tone. Further studies are warranted. My comments briefly, this is a nice study. There are hints of potential for patients with POTS. This is a very difficult condition that seems surely related to autonomic dysmodulation. And this treatment, transcutaneous vagal nerve stimulation, is non-invasive, well tolerated, and has seemed to work. Of course, the headwinds here that it's a small study, there was no improvement of symptoms, the heart rate changes were modest, but it's promising, and I agree with the authors that more study of this is warranted. And indeed, this is how medical science should work, right? You do a small study, you don't overinterpret it, you see some signals, and if there are enough signals, you do bigger studies and see what happens. POTS is a difficult disease to treat, so anything positive is welcome, and I say kudos to the University of Oklahoma team. Okay, so that's it for this week in cardiology. Boy, the AFib guidelines were a lot to talk about. I appreciate that you listen. Thank you. And remember, if you like this podcast, please take the time to write us a comment, give us a review on whatever podcast app you use. And until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.